So welcome to weekly webcast of Indian Medical Association with eMedinexus and our digital partner Librate. As usual, every Thursday afternoon we meet here and we take up some important issues concerning mostly general practitioners in the country. And today we are going to talk about rational use of antibiotics. And Dr. K. Agarwal, our Secretary General and President-elect, will be joining in a few moments. And we are joined by Dr. Narendra Saini. He is a very senior microbiologist from UCMS Delhi, and he has been the past Secretary General of IMA as well. And we are joined by Dr. Sangeeta Sharma, another big name in Delhi. She is the Professor of Pharmacology in IBAS, that is the Institute of Human Behavior and Allied Sciences, and has been associated with government planning of national use of antibiotics for the last around 20 years. So we will be talking to them. It's a very important topic you will appreciate. And in about an hour we should be able to know when to use antibiotics, when not to use antibiotics, what is the rationale behind that. The whole world, in fact, Sani, the whole world is talking about rational use of antibiotics particularly. And I believe antibiotics are the things which are most used and abused and misused. Everything is being done with them. So why such an importance is being given to antibiotic rational use?
Now, this is a very important question, and why rational use of drug is important. 1943, you go back in 1943, penicillin was discovered, and that was a huge success in terms of treating infectious diseases. And we continue to have newer antibiotics, newer molecules, but I think 1987 or onwards, there was a dearth of new antimolecules. And these are antibiotics are mainly are used for bacterial infections, and we have most commonly bacterial infections for which these antibiotics are used. Since 1987 onwards, the newer antibiotics were not coming. At the same time, the antibiotics which we had, they were getting resistant. Bacteria were getting resistant. So new molecules are not coming, but the molecules which are present, bacteria are getting resistant. So the infections rate were getting higher and higher, and people are dying because of infections. So, and then we evaluated what was the reason for this. It was the misuse of antibiotic, which causes resistance amongst the bacteria, leading to more morbidity and mortality. So once the new antibiotics are not coming, and the bacteria are getting resistant to it, so this becomes an important topic that we should talk about rational use of these drugs. Not misuse these drugs, because this misuse of these drugs causes resistance to the organism. So that's why it has become very important, to the extent that USA, which is not considered to be having such high infection as India is facing with, Obama has sanctioned $1.2 million specifically on this creating awareness about rational use of antibiotic. So we have to be very careful, especially in India where infection disease rate is very high.
That's right, Dr. Saini. But Dr. Sharma, you will appreciate that while we were studying in 70s, there used to be penicillin and then tetracycline and chloromfenazole. Then came, with a bang, it was introduced co-trimethoxazole. That was introduced with a big name, it was a big name. But over the years, what do you think has been the, more the number of antibiotics, more misuse, and more resistance and more resistant infections are coming up? How will you, in the last 30-40 years, what has all happened?
See, antibiotics, no doubt, are the greatest discovery.
Sure.
And they treat the most infectious diseases. But the resistance, which Dr. Saini was talking about, is not a new phenomena. As soon as penicillin was discovered, at that same time, it was observed that some bacteria with the use of antibiotics become resistant. That means they don't respond to that antibiotic. So that was a natural phenomena. So initially there were very few antibiotics available, so use was also. as the time has passed, newer antibiotics were discovered, and I remember in my postgraduate days, fluoroquinolones were launched, and they were launched. The specific hallmark of that group was that resistance does not develop to
Yes.
fluoroquinolones. But today, the data, if you see, is full of all the resistance reports to fluoroquinolones as well.
We welcome
See,
Dr. Agrawal.
Namaskar everybody.
So this resistance is not a new phenomenon. So, and the major thing is, use is the key driver for development of resistance. If you use antibiotic, resistance has to develop. So that is why it is utmost of importance that we don't misuse or abuse these antibiotics. When I say misuse these antibiotics, we mean do not use antibiotics for non-bacterial indications. I'll give you an example. We have done lots of studies and found 90% of the diarrheas, 90% of the upper respiratory tract infections are treated with antibiotic. Whereas each one of us knows it very clearly that these two diseases are caused by viral illness. These are viral illnesses. And there is no antibiotic against virus.
Yes.
So, but on the other hand, we see 90% of the patients receiving antibiotic. So if you then if you want to understand this antibiotic misuse, you have to go behind the factors behind why doctors use these antibiotics. Knowledge is there that these antibiotics do not work against this. Mainly, there are patient-related factors. Sometimes there is a real pressure. Sometimes there is a perceived pressure from the patient that we want to get all right. We can't afford to be at home, particularly in this globalization world, and those who are working, they don't want to waste time. Sometimes it is the doctor also feels that I will lose patients. If I don't treat him with an antibiotic, somebody else will give it. Because patient, these days medical shopping is also quite a very common phenomena. People like to consult others, they don't get satisfied with one doctor and then they will consult. So they think that they will lose their patients. Sometimes now because of the Consumer Protection Act and then many cases going against the doctors, they want to be perfect, that I completed all the treatment, gave all possible treatment which I can give. So to prevent litigation or patient complaints, many doctors use. Sometimes there is a misconception that fever is a sign of infection. Fever is a sign of bacterial infection. So whenever patient gets a fever, they think that they need to
Oh, ma'am,
treat
that's
it.
okay, but my neighbor doctor, he writes to his patients amoxicillin 250 milligram twice a day.
Now,
That's it.
this is another misuse
Yes.
of a drug which causes the resistance. Another thing, what happens is, which Madam has, I will like to clarify, that people use antibiotic. We have resistant organisms, as Madam has said, already there. Few resistant organisms are already there, naturally occurring. What happens is, when I give ampicillin or any antibiotic, my natural flora get kills, which is good for my body, but it gets killed. So what is left is all your pathogenic organisms, which were few in number. Now they flourish because they have all the food, they have everything, and they multiply. And multiplication in bacteria is so fast. In 20 minutes, there is one more bacteria is formed, and it is a geometrical progression. So in one day, you get billions of bacteria in one day. So just think of, if you have given a dose which was not required or which was not a recommended dose, it kills all your normal flora, and few lefts which were resistant to your body, resistant organisms, they multiply in billions in one day. So think of that, what problems it can cause later on.
Let me debate it differently, because in an IMA debate we have to think differently. My first different thing is why it is available. Why antibiotics are available? For misusing them?
So I think
Why? So my first thing is, why should antibiotic, government is trying to put down some other schedule. They have brought out some medicines in schedule H1. Why can't there be a complete A schedule? Antibiotic is a different schedule where you require, like, say for example, you brought it for dengue, flu, Tamiflu, 3 only selected centers, only 3 prescriptions are required. Why antibiotic is easily available?
There are two. First, we have already said misuse by in
No,
humans.
misuse is
Second, major cause of resistance
Animals.
is non-human use of.
We'll come back. We'll come
So,
back. But the first
there-
thing is, my first thing is.
You are right, sir.
No, my first thing is IMA stand has to be why antibiotics are at the first instance available because once it is available, it will be misused by chemists, will be misused by quacks, it will be used by other pathies. Why are they available?
Available means available has to be through prescription.
No.
Availability has to be there because they are required.
There are two types of prescription: restricted prescription and prescriptions. Antibiotic has to be restricted prescription.
Restricted
Like Tamiflu. Like Tamiflu, you require minimum three prescriptions. One copy you have to
But
keep.
I slightly disagree because every time you cannot have so much of restriction because they are life saving also.
No. We are not saying don't give them.
Eh,
They are available.
But available how?
3 prescriptions.
But three
One prescription has to be kept. No.
Achha, 3 prescription in the next.
Copies.
One
copies.
Copies.
3 copies prescription. One
That's fine.
prescription has to be kept by the chemist so that you trace who is writing what medicine. So as on today, it's like registering your antibiotic usage. But that's important. Otherwise, it is going to be today with online prescriptions coming in. You are allowing online pharmacies. Antibiotics are going to be more misused. With telephonically, people are prescribing and giving antibiotics. How are you going to check?
I think that's
See,
perfect.
I think with antibiotic there is a paradox. There is a paradox of excess and excess. On one hand, there are a big section of people who do not have access to antibiotic, and for range of infections, you need that many antibiotics. Then, on the other hand, there is a excess, which you are referring. Excess is one in the form of available, and then although in India we all these medicines are scheduled medicine to be available on prescription only.
Right.
Now, devil is in the implementation
But I
part.
think implementation
Implementation part. If these medicines are freely available at the chemist
That's what
shop.
I'm asking. Why?
No.
Why are we not fighting that antibiotics
And she
cannot
has
be
been
freely
associated with the
available?
government.
We
also.
fully
The
agree with that.
government
But we are fighting, Dr. KK, we all are fighting
We
for
are not
this.
fighting. Nobody is serious
But
about it. The government is not
implementation.
serious about it. The
Implementation.
government is not serious about it. They are saying we will allow within which codes will allow antibiotics. Now, if you go section K into Drug and Cosmetic Act, even ASHA workers are allowed to give antibiotics.
No,
On one way, you are allowing them to use. So therefore, there has to be a strict. I'm saying allow anybody, but there has to be a
And
strict.
also, there are 3 categories of antibiotics. One is, frontline antibiotics, which ASHA workers, to tackle this excess problem, so that those poor people who are suffering from get an excess, and at hospitals
I
also
don't agree.
as a first
That I
line.
agree with Dr. KK that it should be
but-
absolute restriction on the
There should
use
be
of antibiotic. Otherwise,
antibiotics are bombs. They can't be.
Yes.
There is nothing
See,
like.
India,
there is no.
I think
Let me
no.
explain, let me explain. There is only one emergency. Which are the emergencies in antibiotic? One is if you suspect streptococcal infection, you need to give an antibiotic as early as possible to prevent the spread to the children. That's one. Two is
maybe any
septicemia.
epidemic, cholera, I think.
No, cholera, there is no antibiotic required. You
but
require more
initial-
of an ORS. you can
yes,
take.
yes.
But antibiotic is not going to make a difference.
In the
Second is septicemia. You need to give the antibiotic at the earliest, whether it is bacteremia, whether it is pneumonia, whether it is anything. The first dose of broad spectrum antibiotic has to be given in time. I totally agree. But there, in a septicemia, amoxicillin, Ciplox is not going to work. So therefore, I'll come back to another point. Now, I'm asking 4 of us sitting here. How long will you give an antibiotic in pneumonia?
5 to 10 days.
5 to 10 days. 5 to 10 days. That means there is a variation of 5 days. How will you decide 5 days, 6 days, 7 days, 8 days, 9 days and 10 days?
Depending upon the response, in 5 days it took
So,
the
response of what?
response, X-ray response,
X-ray
fever
will take 3
response,
weeks to respond. X-ray will take 3 weeks to respond.
and the fever, cough and everything.
Fever may persist even after the infection is over.
I think then still I think you should continue.
So, how long you will give?
See, it's 5 days only.
No,
Clinical
just-
guidelines
just-
are
I tell
needed.
you-
No, I said it's not like
It's a
that.
community pneumonia.
Community.
National guidelines are there. Now we come to that national guidelines.
Coming to that.
I
I'm
am
coming-
national
when
guidelines.
you
are
talk
there.
about community pneumonia, where are microbiology labs
Yes.
access to everybody?
No, but they are
There
presumptive
are-
treatment also.
So
Clinical
what I'm trying to say
diagnosis.
is, what I'm trying to say is today, all of us all of us today are giving antibiotics for a longer duration than it is expected because there is no check.
Secondly, we're not giving for a proper dosage
No,
also.
I'm not coming to that. Dosage is the secondary issue. First is duration we are not giving because there is no proper check. There is no check has to be by the association. Okay. How many times we have come out, bringing a book is fine, but we need to come out with 7 or 8 simple that a chart available in everybody's desk. It's not available. It's not available.
Pathways.
Okay. If you go to, say, I'll give you an example of my hospital. Let's go to one hospital, private corporate hospital, and let's go to the OT. 7 patients going through routine surgeries. All 7 protocols are different.
But prophylactic, and if you're talking about
All
prophylactic
7
antibiotic,
No, I'm talking about normal people, normal elective surgery.
yes.
Perisurgical prophylaxis guidelines. See,
No.
guidelines are there. We need to implement
Now,
those
yes, that's
guidelines.
where it is.
Okay.
There
All
are
7
proper guidelines, national guidelines now are there.
There are,
We have to follow them.
Which guidelines by whom?
By
National-
NCDC.
NCDC.
NCDC guidelines, we have been a part of those guidelines.
Yes,
Those
you are
guidelines,
part of
on those guidelines, 50% of them are not clinicians.
I agree.
Exactly. Because वहाँ पर भी when the guidelines are made, people debate. ये करें कि ये करें. When people debate, so what I'm trying to say is, if we really want to control the menace of bacterial resistance, our approach has to be different. The current approach has failed. Whether
But
it is my
what you
approach,
suggest?
I said, whether it is my approach, their approach, government approach, the approach has failed. The
But
current
Dr.
approach
KK,
has
I just
failed. Therefore, I'm not giving any approach. Therefore, we need to think
differently.
differently.
All
But now,
stakeholders have to come
I give
together.
you one example where the approach has changed. The
Fair.
approach has been, awareness has made a difference. Just think of this time, chikungunya has spread. Everybody, every newspaper you take out or any advertisement you take out, it is saying just take paracetamol. And there are data available now. This time, because even in spite of this fever, people, even the doctors, and we're talking them quacks or even the personally people have not taken except paracetamol, no antibiotic this time. So awareness, one
Even in
thing
dengue,
is,
nobody in the last 10
No.
years, in dengue nobody used antibiotics. So that's not.
so awareness, that's where I'm coming. Awareness makes a lot of difference.
Dengue people never received antibiotics. But then, if they were not using antibiotics, the misuse of steroids was there. Everybody got steroids. If there was no
So
one
that
problem,
is
there was
why
a
that
problem.
is why education, awareness,
Madam,
training,
Madam,
and
I'm
guidelines are very much
I'm saying
needed.
is, can we think of something extremely different? Can we come out with, all of us to come out with, how can it be regulated without giving punishment? How can it be regulated? At the moment, everybody is free to do what he wants.
Sir, I don't, because
Regulation.
regulation has to come with some punishment and awareness.
Self-regulation.
Sir, self-regulation is
I'm
already
not
there.
talking about-
Self-regulation is
No,
already
IMA
there.
has a role,
India-
and that's what we are
India-
here
I
today.
think in our country,
India was
without
separate.
regulation, because there is another section of people.
Okay.
There is another section. There is another section of people which is called quacks, who are using this, misusing this, or using this antibiotic.
I'm saying,
You can't regulate them, yeah.
Regulate them.
No, therefore I'm saying restricted use. Because in antibiotics, see, what I'm trying to say is, if you're going to say quack are not supposed to use any drug, it will be a 50 years journey. But at least something can be come out that antibiotics cannot be given, that every chemist, everybody is that no antibiotic. Why can't we write down on our prescription?
Sir,
All the
again,
doctors that no
it comes out the
antibiotic.
implementation of this thing.
No. Somewhere we are at fault. We are
May-
also
We
may-
are at fault,
may
no
I-
doubt.
We the doctors also are at
Sir,
fault.
we are at
Schedule-
fault. That's why it is there.
What is the genesis of this
Why-
schedule H1?
why-
This is a hybrid between H and X,
I know,
H1. It has the features of schedule H and X that you have to keep a record. When we try to ban some irrational combinations and see what happens. The pharmaceutical industry, they lobby and they go to court, and recently 354 drugs were banned, irrational combinations were banned, so they went to court and the whole process has been stayed
We are
here.
also in the
So,
court. No, we are also in the court. We have been projected as an IMA.
but it will some take.
The matter is.
Tab tak wo
Yeah.
chalega.
Just
But
think of
it is
another
going
thing.
on.
I
Now,
just want to bring
this-
to your kind notice another one thing. Skin ointment. Take any skin ointment.
Yes.
It has multiple antibiotics. It has steroid. It has antifungal. What is the rationale behind it? So the law has to come into
But then
picture
who
to
is-
implement it.
Who is prescribing them? We.
But sir,
But why should the drug
you know,
authorities
we need
allow
to
it?
understand, Dr.
But why should they
KK,
allow
we
it?
need to understand why
I-
people prescribe such irrational. Because, you know, in my experience, I have seen that people
I
are
will-
not
why-
sure of the
I will-
diagnosis.
I'll
When
tell
they are
you-
not sure of the
I'll tell
diagnosis,
you-
they give multiple
I'll tell you why I am
therapy.
asking.
Something,
Yes.
I will
you
tell
know,
Something will work.
Something will
you are asking a very ideal question.
No, not ideal. I'm only talking about the role of IMA. I'm not talking about theory. I'm not talking about theory at all. I'm only talking about what IMA can do.
Ji.
I want in the next half an hour to come out with some conclusions what IMA can do.
Sir, I want.
Just. I'm telling you why my problems. Okay. My problem, I represent the collective consciousness of the GPs together. Okay. Now I get a patient with suspected typhoid. Okay. Every day I hear when I go to conferences that typhoid resistance is coming. Okay. So my patient, I have no data available today. I am practicing in GK. That what is the drug resistance pattern of typhoid in GK? I have no data. Therefore, I end up in giving 2 antibiotics. Whatever you do, whatever you say, I can't take a chance unless I am being told that the pattern of. Say, I don't have any data to say what is the pattern of typhoid fever in Delhi and then in South Delhi. So unless that data is available, so therefore IMA wants that data to be available, zone wise. Say for example, if all the microbiologists in Delhi
networking has to be.
collectively give a data that the pattern that in Delhi the typhoid resistance is say 10%, 5%, 2%, I don't know, number one. Two, that in southeast north zone, like today, somebody came to me for a pollution interview, and I said pollution level in Anand Vihar was 400, in this Mandir Marg was 80, and in civil lines was 200. So I said very simple, if you want to go out, don't go for a lunch or dinner in any hotel in Anand Vihar. You have a 80 वाला, वहाँ पे जाके करो उसके साथ में. So similarly, if I come to know which pattern is arising there, my antibiotic will depend upon the pattern of resistance of that particular area. I don't have. Two, I don't have any data. How many percentage of cases in South Delhi are responding to which antibiotic? I am talking about septicemia. I have no data. How many cases I have which will not respond to any antibiotic? So what happens is when a case comes to the hospital, I end up in giving a antibiotic. Should not call back.
I think
I'll call you back.
Yeah.
Not
There
call
is
back.
a.
No, we end up in giving antibiotic was 10 to 15,000 rupees per day, which is like absolutely. But I have absolutely no data available. No data available with the. So we have. I'll give you another example. What I do in my hospital. I get a patient with septicemia. He is not responding. Okay, so I shift him to West Delhi. ऐसे यहाँ का बैक्टीरियल पैटर्न वहाँ का बैक्टीरियल पैटर्न डिफरेंट होगा. यहाँ की एंटीबायोटिक रिस्पॉन्स
She has already acquired infection.
Yes, the same infection in my area, the antibiotics are not working. When I shift them 40 kilometers away to another atmosphere, they start working. So therefore, I need to know the
But they
pattern.
remain the same
Yes,
even then.
yes, yes.
But because patient has already acquired that infection.
और infection नहीं आएगा ना. See, एक case है होगी different. I'm only trying to say is unless I know at a national level. Today, if I am not having it,
National and regional, both.
I'm talking about national, state, and then local. Unless I have my antibiograms available for different areas, you can't blame me as a GP of not giving an antibiotic. Not one, two antibiotic. Typhoid, everybody is giving 2.
No,
Not
but
one.
clinical guidelines don't recommend
कौन सी
that.
गाइडलाइन की बात कर रही हो?
Sir,
Guidelines
There
are
are guidelines for all the
No,
illnesses these
So
days.
now once the national government has given the
Which
guidelines,
government you are talking about?
NCDC,
There was IMA. There is general practitioners there. There are general
You
practitioners
may
there.
question the
Sir, I
process
agree
of
with you.
development
Many-
of
You can't
guidelines.
develop guidelines sitting in a drawing room.
I
No,
agree.
don't agree
So
with
now
that.
2 ways we have to work.
I don't agree.
No, sir, and don't agree, I also don't agree with
Last
that.
antibiotics were
With those
last
people.
antibiotic guidelines were there, and IMA's participation was less than half an hour.
Sir, I agree with you.
You can't
IMA participation, active participation has to be the second is talking about surveillance. One is surveillance is
No.
must
Again,
without coming
let me
to.
say, in those guidelines, how many GPs were involved?
No, you are questioning the process of
How many
development of
GPs were
guidelines.
involved?
But there is a
You
starting
can't make
point.
guidelines by DM sitting there making guidelines for GPs.
Dr.
No,
KK,
it's not
there's two
possible.
different. One is a guideline making, second how to make the guideline. Absolutely you are right
No.
that we should have a surveillance
There are no
system.
guidelines.
And how to percolate it
There
down
are
to every doctor.
no guidelines available.
Sir.
As on today, you can right away ring up 10 GPs. None of them are aware.
Agree.
The IMA's role
That
is
No, it's
here
not role. It's not my
in
role. It's not my role.
disseminating.
No,
It's not my
Dr.
role.
KK,
My role is to disseminate if I am a part of that guidelines.
So that's where,
If
sir,
government is making, it's government's responsibility to send it to every GP.
sir,
They have a list of 8
No,
lakh
I think
doctors.
here
No,
all
listen.
stakeholders
No.
have to come together.
No,
This
no,
is a
no,
public
no,
health
no.
But
issue.
they have to
No,
be
no.
involved, you know.
agree.
Somebody
Sir,
has to
I
follow
want
them.
IMA to take. You asked me what IMA should do. Now, coming to that, you have taken a very pertinent question. That is must. IMA has to be involved. Otherwise, the general physician will not be able to know. Now, what IMA can do? For that purpose, one is that data has to be there. Otherwise, you cannot make any guidance until we have a national data, regional data, and IMA is capable of providing a regional data. For that, the most important thing, getting that data, and to getting that data involving our labs to send that data. Now, we have to develop it. IMA, whether it's, we have to develop a software,
We are
sir.
trying to-
ICMR has already developed this. They have done some
Right, sir, right,
networking.
network, no, it is a BUNUT. They are trying to, this
We are
data
trying
is a
to,
BUNUT.
are you trying to, what are you trying to convince? We are not being able to understand.
I
The
said-
debate we are going something different. We are trying to defend if the existing guidelines are existing.
No.
If I'm only taking an hypothesis. My hypothesis is that resistance is increasing. That means current policy is failing. This is how I am starting. You are trying to defend the current policy.
No,
Then the debate is not
sir,
there.
no, it's no
Then the
defending
debate
that
is not
policy.
there.
No, not defending that
Use
policy.
is the key driver. Use is the key driver.
Yes.
And clinical guidelines are the important tools to curb this misuse of antibiotics. You know, you may agree with the end product or not, developed by NCDC or not, but at least there is a starting point. There is a starting point. You can start, and these are dynamic documents. These are not static documents.
So
You can
broadly,
revise
we are on the
these.
broadly we are on the same page. We are on the same.
You are not
is
understanding that IMA is opposing all guidelines. You are not understanding
Like
that.
we-
Why?
why?
Listen to me first.
Because we
Listen
don't
to
have
me
the data.
first. You are,
we don't have.
No.
They're not based on
no,
data, proper
no,
data. That's
No,
what it is.
no.
Okay.
Guidelines making is not the job of the government.
Mhm.
Because the government's guidelines will not get updated for 5 years.
G.
Guidelines get updated every 3 months.
Ji.
The job of guidelines has to be with the associations. So all the associations should sit together
Agree.
along with the government and make guidelines. That doesn't happen. That
Somebody
doesn't
has to
happen.
take initiative.
No. I said that doesn't happen. We are opposing all clinical establishment guidelines. What is our fight in Clinical Establishment Act? The government is making standard treatment guidelines. We are opposing it. Why? Why we are opposing it? All those guidelines we have been made has not been updated for 5 years. And when we sit in Medical Council of India, people challenge that. कि guidelines के हिसाब से treat नहीं किया इन्होंने.
Agree.
So guidelines means regulation. Guidelines means regulation. Guidelines have to be
Guideline means
updated.
it is no. I slightly differ from that.
Have
You
you
are
ever
more,
said
you
it?
know.
You are not in the council. You haven't seen
No.
enough cases in the council.
But
I have
guidelines are
seen-
not as regulation. I think.
Regulation.
They are guidelines only.
No,
They
I
are
don't agree.
voluntary.
I don't agree, madam.
And
I don't
no,
agree.
8 minutes. Let me just complete this. You know,
We have taken actions. Yes,
as a
But then
concept.
it's action if it is
No.
justifiable thing. Then
I
it should
think
not be.
I have got his point. What he's trying to. These are guidelines only. They are not law. They are voluntary as a concept.
Which
but
law?
in
No,
the
define
let me
me.
just
No,
let me
define
just
me.
complete.
When you say that these are guidelines, not law, which law you are quoting?
I'm coming to that.
Which
You know,
law you
as
are quoting?
first
Which judgment you are
sentence
quoting?
was
Which judgment you are quoting?
as a concept, treatment guidelines are guidelines. Okay, they are given for average patients. They are not meant for 100% of patients because patients present in different ways. Some are atypical. They respond in different way. So these are mainly for average kind of
We are not talking about
presentations.
antibiotic guideline. We are talking
Okay,
about the
just
word
a
guideline.
minute. No,
There is a difference between
just a
when it
minute.
comes to
But
guidelines.
now the question is based on this, so we are
No,
talking about-
when it comes
because
to
again the
guidelines.
implementation part is important. Under the Clinical Establishment Act, the government of India has put some guidelines over there. You know, I agree with you fully. How that guidelines were made or what was the process involved is not very clear, and even they are not updated. From time to time. So the way again, see, the devil is in the implementation part. how have you implemented, how do you project, these guidelines are usually for education of the people. They know the source of the person, authentic source of advice, recommendation, that this is the current advice for the management of such and such infection. So now this has been wrongly put under the Clinical Establishment Act. This should have been on the guidelines portion, and
Before I say, just listen to me. In Clinical Establishment Act, not following anything written in Clinical Establishment Act is an offence. Okay? So therefore not following standard treatment guidelines is an offence in Clinical Establishment Act.
There, the
It's an
doctor
offense.
should be able
Okay.
to give justification
I'm
when
not-
he is not able to follow the guidelines.
Yes.
Then I just come out with
He
one
should be
second.
in a position
पूरी
to
बात तो
give.
सुन लीजिए, मैडम ने आंसर दे दिया कि then कि doctor has to give a justification. That means he can be caught under the केस हो जाएगा, आपको बुलाया जाएगा, आपके ऊपर में एक्शन हो जाएगा, आपको इंक्वायरी होगी, इंक्वायरी में आपको जस्टिफाई करना पड़ेगा. Therefore, guidelines makes you that I have to justify. When I become justified, becomes
Sir, otherwise also that helps you.
No.
So guidelines help you. Suppose now
I
listen
am
to
not
me,
going to
sir.
follow a guideline of
Suppose
5 years old.
no, you may not. You may not. Otherwise, you are always liable.
Anyway.
Something. No. I have to answer this. Otherwise, suppose there is no guidance, you are always answerable to your always answerable to your deeds.
You are trying to
But if you are
you are trying to justify that IMA stand against clinical establishment is wrong.
No. This is
I
not.
think this
There's
is
two different
an
things.
issue.
I am talking about guidelines. Suppose
They are
no.
against-
No, sir. Let's come
I'm
to
not
it.
debating here. IMA is absolutely against
Absolutely fine.
guidelines.
No.
No,
They are against
not guidelines.
Guidelines cannot be
Putting
made by the
under
government.
Yes,
CEA.
that's
Cannot be made by the medical council.
I agree
That
with
I
you.
think
Yes, sir.
everybody will
No, I agree with that. The guidelines should not, but somebody, sir, you agree that there should be some guidelines made by associations?
Yes.
So that's where. Now coming to those things. Now
But we are
let's
not-
start. You said.
If I-
Let's start now with you said.
Therefore, the government, all those funds they spend in making a guidelines, they should give it to the association.
Yes,
Follow the procedure through the association.
agree.
Make guidelines.
That's what it is. No,
That's
in that
not-
we are
If they
absolutely. I think we are
don't
talking the same
If
thing.
they don't give the
We are-
job to you, why don't you take it up
It's not
yourself
possible.
and say
It's
Sir,
not
that?
possible.
Sir.
Other people will not come.
At
Sir,
least
there are two
IMA
bodies-
members can follow
No,
it.
when
because
there are-
they
Sir,
can-
I
Sir,
think guidelines
when
will be
there are two
portable.
bodies making guidelines together, either government says we will not, then we will make.
Sir, I think
Today, government, the Ministry of Health says we are going standard treatment guidelines of every disease under the Clinical Establishment Act. That's the dispute.
Sir, I think let's take away this dispute, but we all agree that guidelines has to be there, and I also agree that guidelines has to be made by physicians who are doing things, not by the government who are away from it, and IMA should be a body who should be taking that active role in that,
lead in
taking a
that.
lead in
Therefore, we
that.
failed because IMA is not involved. So, therefore, these guidelines have no value.
That
This
is
is what I'm saying.
That is
What
right,
I'm trying to
sir.
say is
But
you are
we
trying
can
to
put
blame
this-
it. We are every day. See, you have to understand. Every day the blame is going to GP. कि दवाई को मिसयूज कर रहा है. मैं उसकी बात कर रहा हूँ. मैं GP को रिप्रेजेंट कर रहा हूँ. वो मिसयूज नहीं कर रहा. उसे पता ही नहीं क्या करना है.
So that's where the role is,
Yes,
making
sir.
some guidelines which IMA should make,
IMA
or IMA
IMA
Sir,
तभी करेगा
sir,
जब
awareness.
IMA तभी करेगा जब पैरेलल कोई दूसरा गाइडलाइंस नहीं बना रहा. अगर कोई दूसरा पैरेलल साथ में गाइडलाइन बना रहा है तो आप कैसे बनाओगे?
नहीं.
अभी भी राइट अवे रोज हमारे को लेटर्स आ रहे हैं AMR के कि एंटीमाइक्रोबियल रेजिस्टेंस के ऊपर में गाइडलाइंस बन रही हैं, अपडेट हो रही हैं. ठीक है, दे डोंट आस्क अस कि आप खाली हो कि नहीं हो. हमें तो इनवाइट आता है कि इस दिन मीटिंग में आ जाओ. वी शुड बी द मेन पार्टनर. वी शुड बी द पर्सन डिसाइडिंग द डेट कि कब मीटिंग होनी चाहिए.
that is, I think, agreeable.
doesn't happen.
There is nothing,
That doesn't happen.
no controversy
We
on
are,
that.
they will never say कि आपका आना बहुत जरूरी है. This is what I'm trying to say. Guidelines can try to understand. In dengue and chikungunya, we have failed. So all our strategies, whatever are existing, have failed this year. So you cannot justify government की जो strategy है दिन में काटता है, we have failed. क्योंकि दिन में लगे रहे, रात में आना चालू कर दिया उसने. आप ये कह रहे हो कि जो है रात में प्रिकॉशंस मत लो, घर के अंदर आता है, बाहर तो एडीज एल्बोपिक्टस comes outside the house. वो घर के अंदर नहीं होता. हमारी strategy गलत है कहीं ना कहीं. So I'm only trying to say is, I'm only saying one word. Antimicrobial resistance is increasing. We are concerned in a private sector, unless you come and see in the hospital, we are seeing one death every day of septicemia. The hospital-acquired infection rate is crossing 15%. Is crossing 15%. We are afraid. we are afraid of admitting our patients in the hospital. We are now talking about home care. Because we are afraid कि मेरा patient में ICU में बोलते हैं ICU में जाएगा मर जाएगा. That's the language we are talking about today.
Absolutely.
That means whatever policy as on today are existing, तो practitioner है वो डर रहा है आज की डेट में. Hospital acquired infection से. So we need a paradigm shift in our thinking, and that paradigm shift in thinking, I have no answer. I am not giving any advice. Paradigm shifting is अभी भी जो हमारी thinking चल रही है वो justify करने को चल रही है जो existing system है. I am saying is existing system is not the answer.
Agree.
That's all.
No,
It has
we
failed.
need
That's
a
why we are
multi-pronged
trying.
approach. We need a multi-pronged approach. Alone IMA or alone government
ये
or
बात नहीं
academicians cannot handle this.
Even public also.
Even public. So we need to have a multi-pronged approach. We need to educate public. We need
I'm
to.
not anticipating it happening in the last 10 years, the next 10 years.
So we
Sir,
need to
no, I
do
agree.
some
One more thing I will
advocacy.
add.
Advocacy.
Everybody, multi-pronged approach in which everybody has to be active partner.
Yes.
I'll say you talk about hospital infection control. In the same, the society has to be an active partner in that. The hospital has to be active partner in that. Doctor working there has to be partner in
See,
that.
you are trying to
Only
just,
then.
see, both of you are trying to, as if here it looks like that a debate is going on. We are not looking for a debate. Let me explain. I talked to NABH. I am a board member of NABH. And I asked them, can you share us the data of antibiograms of every hospital? They said, we can't. I said, then what the hell you have the data for? I said, you are asking a data, NABH may to certify that you say that antibiogram department, every hospital must have an antibiogram, but you are not sharing it. So I asked my hospital, give me antibiogram data, it's not available for me in my hospital, but they give it to the NABH. What the use? What is the use of an antibiogram data available with NABH if it is not going to be used to
That's
public
where
health?
the role of
So
IMA is bodies come.
somewhere, I say you have to understand the difficulties today. My difficulties today is I don't have an advice. There is no helpline available for me to advise which antibiotic to use. I am in a fix. In my hospital, when a patient is admitted, I have absolutely nowhere. So we end up in giving is जो सबसे heavy antibiotic है वो चालू कर दो. We are totally see.
That's where
There is only 1 or 2 hospitals where microbiologists take rounds. In my hospital doesn't. So we end up in misusing antibiotic out of compulsion, not out of a choice.
So answer
Not
comes
out of
from.
ignorance.
So I agree. The answer comes from here only. That as a private sector, we have to be actively involved ourselves in our own center.
in the answer, okay, you don't agree
in
with
our
the
own hospital, we have an antibiotic policy.
I have no choice.
We can have an
No, no,
antibiotic
no.
policy.
Who will have it?
if you
Our
There is no
hospital,
rule. There is
our
no rule.
hospital
There is
can
no
work
rule.
on that.
There is an infection control committee, but that is only to report to NABH
No,
requirement.
no, sir. No, sir.
The idea
slightly
is to
disagree with
improve
that.
patient outcomes
Yes.
and have patient
कितने
safety.
hospitals में हो रहा है बताइए?
So this is where
Sir,
you
that's
know,
where we have to create awareness,
yes,
sir.
this is where
Ki among ourselves-
See, if you don't agree with the national one,
Sir,
fine.
one thing, we totally against Clinical Establishment Act. It has no role to play in Indian system. But at the same time, our hospitals has a role to play in infection control, that we can make our own antibiotic policy and we can have a
You are
surveillance on
all
that.
talking about something which is not happening.
Which is not
No, but
happening,
it
but
has
it
to
is feasible.
happen.
Are the
It has to-
are
is it
private
feasible?
hospitals under your control?
That's
This is
where
what I'm trying to say.
Sir, that's where
Are
the-
private hospitals under Medical Council of India or State Medical Council control?
There
They
is
are
a-
not.
They are not.
They are not. Therefore, you are talking something which is not
But
humanly
they-
possible.
no.
So therefore the policy, when you come out into a policy, everybody has to sit together. But unfortunately, that's not happening. That's what I'm trying to
We
say.
need to
We all
create,
We all agree on that.
It's not happening.
There is no
not
disagreement on this.
It's not happening.
Multiple stakeholders
Sir.
have to come together
Yes.
to tackle this problem. This is
Now,
not one
I'll give you
person's
an
problem.
example. I'll give you an example. The government of India is coming out launching their antenatal checkup program on 9th. Okay, so I'm just coming from there. That's a bit. I got delayed. This says you post all your doctors in this all the districts on 9th of every month. You post general practitioner. They should come and do service. Will that work? Will you be able to do it? My
No, it will not work.
Nobody will do it.
Nobody will do it.
9th is coming. 9 days, 10 days are left. Government is anticipating that every private doctor will come and sit into the PHC and provide them antenatal care on 9th of every month. Is it so easy?
No, not at all.
So therefore I'm trying to say, but somebody advise them, ऐसा हो जाएगा. Somebody advise them, ऐसा हो जाएगा. So what I am trying to say is somewhere down the line, we are concerned. So my concern is very clear that the super bug is really disturbing us. We are getting cases where septicemia, we are seeing patients death. We are afraid. Septicemia, every day we are losing one patient, and that is not acceptable to me. That's all.
Anybody,
And in today's policy, I don't find anything improving. It will go
All
worse.
advances,
It will
the
go worse.
advances which we have achieved
So-
will be reversed if we don't tackle this problem right
So
now.
we all have to now. We have to find solution ourselves because it's the medical
Yeah.
community which has to find solution. The
Yeah.
government cannot. Government would not be there. There will
Who
be
is government?
stereotype in their approach. So you agreed. You said in one point that we all doctors have to do. IMA has to take a leading role.
Yeah.
Now the monetary part is different, but at least we should have a policy in that. IMA can have a policy in the rational use of drug, creating
Okay,
awareness
let me
in
explain.
people,
Let me
creating
explain.
awareness
Let me explain.
in
Education.
doctors.
Let me explain. See, let's go to the facts. TB program, IMA is out. Out. Okay, this is we don't need IMA. Leprosy, we are not seeing. In leprosy program, we are not seeing. In deworming program, we said we want to be in. This is we have no funds for IMA. For IMAs, private practitioners. Adolescent clinic started, IMA is out. Total MCH program, vaccination program, MCH program, IMA is out. They want antenatal program doctors to be posted. Then we said, how will they be reimbursed? They said, sorry, no funds are available. No funds are available for private sector. So that means that all government funds are available only for 20% of the society who are seen in the government sector. For 80% of the society is seen by the private sector. Nothing is available. We started with a big launch of PVPI, Pharmacovigilance Program for India. I started. I might have spent around 4-5 lakhs IMA money till today. I've been asking them, give us some funds for at least for communication. If you want me to communicate to my 2 lakh members on a regular basis, at least reimburse me that communication charges. This is, we have no funds. So it's not easy. When you say IMA should do that, it's not easy.
It is not easy, but under your leadership, I know
No,
we will be.
no.
We have the capability and
No.
capacity to do
we
that.
have the capability, we have the zeal to do that. But it's not. We have to think differently.
Just zeal to do it, but you have the capacity to make it happen.
We are trying to do as much as possible. We are trying to create an awareness. We can only create awareness as much as possible. What I am trying to say is somewhere around the wrong. The current approach to dengue, malaria, TB, somewhere we are wrong. Somewhere we are wrong. We need to work and sit together. I don't find any MCI representative in these meetings. I don't find. When I go to government, I don't find even a single state medical council representatives. I don't find state medical council presidents in those meetings. So when suppose I'm making antibiotic guidelines, all the state medical council presidents, all the state medical IMA presidents, government, there should be 100 people sitting together and coming out with guidelines so that everybody implements. It's not happening. It's not happening. Which guidelines are we following?
I agree.
See,
There has to be a
I think we are not
multi-sector
taking it
people.
seriously.
I only want to know is when a new antibiotic is
That is why
launched.
the magnitude of the problem has grown so
Sir,
much.
We are not serious.
at least I will say, I'm not supporting government at all, but at least this step has created awareness
We go to
among
WHO.
ourselves.
We go to WHO. This is sorry. Come through.
That's
Ministry
the
of
problem
Health.
we are also facing.
Sir.
I am part of an NGO, Delhi Society for Rational Use of Drugs. We've been working on this for last 20 years. We are also facing the same problem. No funds for societies, who are doing meaningful work,
They are not-
who are doing meaningful work, and involvement. It happens. But we are being optimistic. We don't lose hope. And even a drop in the ocean will work. Take it in a positive manner.
I am myself seeing one death every day, so I'm concerned.
No, everybody is concerned about it, but they have their own
the
ways
concern
of
has gone differently. That now we are getting afraid. We the doctors are getting afraid कि हमको ना हो जाए infection. Now we are. So now if it has gone to that level, that means it is a matter of concern.
Agreed, sir. Now, for that, I think there are solutions have to be come out, and solution has to come out from ourselves only. We have seen the government, the way it works, and rather you are very right in terms of guidelines. these guidelines, at least a step has been taken which creating awareness among ourselves. I totally agree that these guidelines are based on the data which they have collected through the government hospitals only. They have not been able to receive any data from the private sector, so that is where 70% people are being treated. But at least a beginning has been made for all of us that now we should take up this.
Where is the government data available?
They said
Where is the government
they
data?
said
Their
that.
books.
No,
They
see,
said that.
even
They
if
said
that
that.
data is for Dr. KK, even if that data is available to the GPs, many of times they will not be able to interpret that
No,
data
I don't agree
also.
with that. I don't
So
agree with that.
as a
I
last
don't agree with
step,
that. Please don't
no,
make that
no,
statement.
no, it is very
No, that's not correct.
well proven.
No,
No,
I think
That's not
they will be able to justify. They will be able to, but it's awareness. I take your point where
Our
you said.
GPs are far better than RMOs working in the government hospitals.
No,
no, I am not saying that they are not good. No, please don't take it that way. It is. I don't.
I agree with you,
that.
sir. Our GPs are as
No,
good
I
as
didn't
anybody.
mean
I know. I
that.
think you also don't mean that.
I didn't mean that, but I
She
said it
also-
in a different
Yes,
way.
yes.
That interpretation of these antidiagrams and all
Agree.
that is also required.
Anyway,
It is
let's
not
have-
only
let's
the
have-
antidiagram.
let's have-
Small and poor countries can eradicate malaria, for example.
Sri Lanka,
it
yes.
means they had a will to do it.
Only they can do it. So the NDMC in Delhi
Ah.
has been able to reduce this notification area because that's small.
Yeah.
Only small people can do it.
They-
See,
even-
so NDMC in Delhi has been able to, they have declared as notification area.
But sir, we have small area like that.
No, no.
Yeah.
Why
Why
we
don't
have
they
a governance,
Delhi and
which
Sri
is
Lanka
governance
do it?
is small.
You
We have to
started
take the
that.
first
We
step
started with the
here.
polio from Delhi.
Yeah.
We did it.
So-
No, let's go
Let's
back.
take a first step, sir.
Let's go back. No, first step will come back. Will come back. So first step is unless Naddaji announced 2 years back that in every committee IMA will be there, but it's only on paper. It's only on paper. It will not. It will not. See, a person like me who has spent so much time, the next person may not spend so much time. Okay, so it is not looking like that we are finding solutions for 80% of the society. All our schemes are for 20% segment of the government sector. Let's be true.
Yes.
See, when they started the adolescent clinic, I asked them, I said, why only in government? So their focus is only in the government sector. So their focus is not in the 80% of the society. Paradigm shift is needed. Paradigm shift is needed. I told them, why can't you have a DHS for private sector separately? Whose job should be only to coordinate with the private sector? Who stops you? Once you have a DHS of a government department, that will be also a separate post within the government whose job is to only coordinate with the general practitioners. Through IMA or through other associations, they will be able to do. But that's soch nahi hai abhi. But let's go beyond that.
Yeah.
Let's try to understand. Let's quickly, because time is less. Let's talk about which guidelines are available. Okay, number one. Are guidelines available for, say, abdominal pain, for H. pylori? Do we have guidelines available for H. pylori? When I'm talking about where the antibiotics are most misused. Most misused. Today, most misuse is Norflox DZ, Ciplox DZ. Patient में पेट में दर्द हो रहा है, single diarrhea हुआ है, 2 गोली खा के बंद कर दे. This is the commonest. Do we have guidelines for that? When to use, when not to use? I'm not aware. I'm asking.
Not use is not available, but rational
When
use
to use is available.
Yeah,
So we should come up.
Our society, Delhi society, has developed ready reckoners for this. For the people.
क्या है? क्या आपके पास कोई आएगा आज की डेट में?
For example, diarrhea. If the patient is coming with diarrhea, patients usually present only with one type of infection. So generally, and 90% is virus. Then comes the amoebiasis, and then comes a small proportion of.
आपके पास एक पेशेंट आया जीपी के पास में कि मेरे को कल सुबह से 10 लूज मोशंस हो गए हैं. अब क्या करोगे आप उसको?
तो ORS, there are treatment guidelines for treatment of diarrhea. You have to correct. नहीं देंगे.
कब देंगे फिर हम?
When there are signs of bacterial illness,
Yes,
for
sir.
example, if there is a blood is
there.
blood
Blood is there.
is
Blood is
Pulses
not
are
a
there.
sign of infection. Blood is a sign of amoeba.
With pustules and all these things are there.
इसका मतलब यूरिन में स्टूल चेक कराओगे?
See, this is a clinical diagnosis.
diagnosis.
This is a clinical diagnosis. By diarrhea, we don't need
Now,
laboratory.
coming to your point. I will start a presumptive treatment
क्या?
on the basis of clinical.
Yeah.
Suppose I am feeling that it is a case of amoebiasis, which is a clinical. I will start with metronidazole plus along with 400 milligram TDS with the diet, and I will go for a stool examination and culture along with that, and the report will
Culture has no
come. No,
role.
suppose I'm talking of bacterial infection can be there. So if the facility is there, I will go for it, and then I will go to a definite
See,
diagnosis.
Dr. KK, 90% will get all right. It is a self-limiting illness with rehydration, with ORS, and
Simple
depending
diarrhea.
on.
If it is simple
Well,
diarrhea, yes.
90% is simple diarrhea
Simple
only.
diarrhea.
Why are we
Easy,
bothering
let me
about
talk.
a very small portion?
No, we will not bother
We
it.
are again defending the existing policy. We are not. I'm
No,
saying is
but it-
today.
this
listen
is-
to me. I said today, 90% of the time, the misuse of antibiotic, number one condition is diarrhea. Okay. In diarrhea, everybody gets Norflox, TZ, and now O2 has come.
That's the current practice.
We are talking about current practice only.
But
We are talking about current practice
irrational
only.
है.
No, मेरी बात we have to understand. अगर हमें उसको rational बनाना है, तो हमें solution लाना पड़ेगा ना. Solution is not that कि उसको पहले stool culture कराओ.
No,
वो
not at
आएगा
all,
नहीं.
not
No, not at all. I
at all.
never said that.
Stool examine भी अगर आप
ORS.
कराओगे तो वो नहीं आएगा.
No,
It's
no.
a self-limiting illness.
Self-limiting.
ORS is
वो
the
तो
treatment.
we are going detail. That's what I said.
Yeah.
But otherwise, self-limiting with the guidelines says that also.
I think I'm wrong in my, because we have started debating on something on a wrong track. I'm trying to say is, if your answer is correct, misuse should not have happened. I can't blame my GP for misusing it.
No, but now
Because
we
he
need to
is compelled.
integrate, na?
He is compelled to use an antibiotic. Therefore, I'm trying to find out is where we need to have a change.
He is
Where-
compared
where-
because there was no awareness was not there
Yeah.
in
My
that.
first thing is, again I come back is, Ciplox is that. Why the hell we have allowed it to be marketed in the country? That's my first
See,
question.
I think
Because
Dr.
what
KK,
happens is-
let's talk about things
We
which are
already agreed on
out of
that.
the
We
domain.
already agreed on that. We are like multi.
Listen to me.
Okay.
Once Ciplox TZ is available, okay, some of us are promoting it somewhere. Ciplox TZ cannot work on, because in amoeba, Ciplox is not required. In cholera, metronidazole is not required. Okay. Suppose she says this is an irrational drug. Fine. Suppose it is an irrational drug. But सबसे ज़्यादा misuse is Ciplox TZ 2-stat. Commonest. For every diarrhea, they give Ciplox TZ 2-stat. Okay.
If we
Now-
stop using it, people will stop producing it. We are using it, the people are producing it.
अब आप मेरी बात नहीं समझ पा रहे हैं.
Promoting it.
See,
मैं आपको
regulatory,
बताऊं,
definitely IMA has a role and can make recommendations to DCGI, but these are largely, I think, for topic of today, are outside of our control.
हम
Directly
बार-
we cannot
Sir, मैं उसी पे आऊंगा, sir.
affect
Like
the
we said,
regulatory issues.
In dengue, in malaria, in chikungunya, like we created awareness that
Yeah.
only use paracetamol. Similarly, if we start promoting, if IMA take that role, I think we are
Yes.
taking it. Ki no need of any Ciplox TZ in case of a simple diarrhea.
Yeah.
I think things will solve.
Few years back, ORS, nobody
But
used
yes, ORS
ORS,
has done it.
but because
Lot of
since everybody
positive,
started
very
talking
good.
about it, now people are themselves
People-
taking ORS.
Even zinc is
Now,
Yes.
again I come to this point, awareness. Somewhere down the line we said that sometimes the clinician is forced to write antibiotic because of a patient pressure also.
That's what
Here
I said
comes
in the beginning.
when we have created awareness among the people also that no antibiotic is required, he will be very satisfied in whatever the clinician is writing that medicine. So awareness among the people also in the community is required, which I think IMA has doing it, and really it's a commendable job which is doing. We should do it more forcefully.
Last
under
year
regulatory.
you were preparing some guidelines. I made one slogan there: "Get well soon without antibiotics."
Yeah.
Something like that. Slogans
And
can be
secondly, sir, I
developed.
agree.
And this
That
time
we
the
need-
patients were not
Sir.
asking for anything
Yeah.
else than paracetamol.
And Dr. Monga, I need, IMA has to take active role. How the money is in what? Surveillance. Guidelines can only be made through the data, and for that data we need
Without
this,
surveillance, we can't
and
make data.
and for that software is needed.
Again, software is ready. IMA made the software. Software is there on our website. Okay, we have a complete disease surveillance software is available on our website. Nobody fills it up. Nobody fills it up. Nobody fills it up. I
think
started.
this is.
So nobody fills it up. So to fill it up, you require a system. You require a system. If you are going to ask, same thing I said. I said if I am going to tell people कि तुम 9 तारीख को गवर्नमेंट में जाके free antenatal care कर दो, it's not easy. It's not easy. GP doesn't have time. GP doesn't have time. So if we really want is, say, my purpose of this was not to educate people what is rational use and what is not rational use. IMA debates are only on what IMA should do. I personally feel that whatever we are doing, somewhere we are failing. When I don't say government is failing, I say all of us are failing because resistance is increasing. If resistance is increasing, we need to think differently. In last 1 hour, we have not been able to bring out even a single issue. We have not been able to come out with even a single guideline what IMA should think differently. Awareness create karo, this is routine work. IMA's job is there. We create awareness. I have no answers. So my idea was to come out with some out-of-box thinking. What can be done? Because my people are dying. I have stopped going to intensive care units. I don't spend so much time in intensive care unit because I am afraid I am going to catch infection. So therefore, we are disturbed. The practicing doctors are disturbed. Of the continuing rising hospital-acquired infections.
You said out of the box thinking. Can we get IMA members together and then they take a pledge that at least some of the rational combinations which you
That
discuss
thing we started on our website also.
and they stop
We
using
have gone to
those.
the court against all this.
No, but availability is one issue. I agree with him. But if you stop using it, it will decrease the pressure on of development of resistance.
Out of box thinking is where you said my doctors are afraid that we are dying.
Self-monitoring.
Even they themselves are feeling that they can be infected with such kind of research. That is, I think, a very plus point to generate that kind of awareness and that kind of knowledge to them that do not use it rationally. Wherever this is not required, don't use it. Don't get pressurized by the law or by the society that you have to write an antibiotic. And he has to be protected by law also. That if he is not writing antibiotic, he is justifying himself.
See, as you said, most of the doctors use this irrational treatment because they are not aware of the right way of doing it. So I think that's the starting point. We tell them what is the right way of doing it. Antibiotic stewardship program. We don't do it for NABH or NAQS or any other accreditation program. It is for the infection control of the hospital only. Instead of focusing on infection control and prevention, we focus on antibiotic use.
Sir,
if the sanitation improves, laundry, housekeeping,
like you said, NABH program that we are doing it for. I have worked in an NABH accredited hospital. No doubt we started with that.
Yeah, but then
no doubt we started with that. That I have to create data which will suit NABH and they will give me accreditation. But later on, after first accreditation, I never thought about that I have to take accreditation because if I don't present my data, I will not get accreditation. I did it because it was helping my patient.
Yes.
It was helping and saving drugs. And it was other thing. It was saving. I have seen that we reduce the cost of the patient also by not prescribing drugs.
Dr. Monga, there are strategies at the national level, regional level and the local level. The local level can do it. It is within our control. We can do it. Hospitals, many of the members work in hospitals, they can get together.
Madam said one thing, concluding that initially we can start among us. GP alone can do it, but local hospital can do it. It costs nothing. It costs nothing. At least we can present, and they should do it. And nursing home societies are there under IMA, and these nursing home society under IMA, that's I think out of the box thinking which I thought. Nursing home honors and then nursing home associations should give this data to IMA, so we will have the national data through these nursing home honors, and we can have our own policy which will decide about 80% of the population.
I think we need to work a little more on this. So we have already run out of this time. But we definitely agree that this is a serious issue and we have to seriously think about it. And where to start, it's a big question. It has to be the responsibility of the government, Indian Medical Association, nursing home associations, corporate hospitals, and the society as well. and Director Health Services. All these stakeholders should join together. Awareness is one part of the story, but definite surveillance and action on these issues is the need of the day. We thank you for watching this webcast, and we'll be again with similar type of a program next Thursday on 20th. And we thank Dr. Narendra Saini and Dr. Sangeeta Sharma for the same. Thank you very much. Thank you for watching.